Technique of renal function test with the ureter catheter. The routine I prefer is the following. If there is question of hemorrhage from the kidney, no instrument is passed into the ureter until the precise nature of each urinary jet has been carefully studied. If the wax-tipped catheter is to be employed, this is passed before the ureters are catheterized. If any difficulty in finding the ureter mouth is anticipated, inject 5 cc's of a saturated 0.6% solution of indigo carmine, and do not introduce the cystoscope until this appears in the urine. Finally, the ureter catheters are introduced, and the cystoscope is held in place until one is certain that the catheters are working well. The first 20 to 30 drops are permitted to escape in order to assure uncontaminated urine. Then, with the cystoscope still in place, at least 0.5 cc's of urine is collected from each kidney for microscopic examination, the character of the jet being meanwhile noted as evidence of pelvic or ureteral dilatation. The specimens thus obtained are then set aside, the cystoscope withdrawn, 1 cc of phenol sulfonaphthalene solution injected into a vein, and a second set of specimens meanwhile collected for urea estimation by the hypobromide method. From time to time, after a lapse of 2 minutes, a drop of urine from each catheter is permitted to fall into a white pus basin containing a few drops of sodium hydrate solution until the red color appears in the urine. The ureter catheters are then transferred to a third set of specimen bottles, care being taken to note the time of appearance of the dye in the urine of each kidney, and an effort being made to estimate whether undue delay in one side is caused by inefficient action of the catheter or of the kidney. In deciding this point, the concentration of dye in the urine is a most important factor, for if there is delayed output on account of kidney inefficiency, the concentration of the dye is sure to be low. While if the delay is due to catheter inefficiency, when the dye does appear, it is in considerable concentration. Specimens for phenol sulfonaphthalene estimation are then collected for 10 or 15 minutes, depending upon whether the findings seem likely to prove obvious or doubtful. Finally, a fourth pair of specimens may be collected for bacteriological examination if this is to be made by culture. Footnote: the order of procedure above described is the one calculated to give the best results. The first specimen obtained should be used for microscopical analysis because it is likely to contain less ureteral epithelium in blood than any of the subsequent specimens. On the other hand, this first specimen may be contaminated with pus from the bladder. If there is any question of this, a microscopical examination of specimen number 2 should be made. Specimen number 2 is essentially for urea estimation. This may be compared with numbers 1 and 4 after these have been centrifuged, thereby getting a series of observations that may be of advantage in estimating changes in the kidney flexibility. Conclusions derived from this series must, however, be taken with a grain of salt, for the first specimen is very likely not only to be contaminated by the urine from the bladder, but also to show the effect of reflex inhibition due to cystoscopy. Finally, the reason for taking the specimens for culture last is not only that these are the least likely to be contaminated from the bladder, but also because any antiseptics in the ureter catheter are most likely to have been washed away. My catheters are so strongly formalized that I find it necessary to delay the culture specimens to the last, and also to drop them immediately into culture tubes. Otherwise, the formalin kills the bacteria before they can be transferred to the laboratory.